All right, everyone. We're going to get started, so please take your seats. Thank you. So we have a really exciting panel before us on pharmacy programs, achieving value and affordability. Welcome back. I hope everyone got a chance to at least step outside and get some fresh air. The pharmacy and medical pharmacy costs, both prescription drug and medical pharmacy costs, are an area of healthcare that affects us greatly and really affects our members. Our members need medications for specialty conditions or for various treatments that require a broad formulary. Dr. Richard Sun, our Chief of Clinical Programs and Appeals Section, is here to lead the discussion. He's joined by a panel of presenters, including our own Dr. Kathy Donison, Chief of the Health Plan Administration Division, as well as health industry guests from OptumRx, our current pharmacy benefit manager, and and Jamie Robinson as well. And I'll let him introduce the panelists, but I'll ask all the board members, we're going to hold questions until the end of the panelists' presentations. With that, turn over to you, Dr. Sun.
Thank you, Ms. Mather. If a physician practicing 50 years ago in 1968 were to have gone into a coma and were to wake up today, she or he would be amazed by the drugs that we currently have. Drugs for conditions that were prevalent in 1968, such as cancer and heart disease, have improved greatly. And there are drugs for conditions not even known in the 1960s, like HIV and hepatitis C. However, she or he would also be amazed at the prices of drugs. For example, colchicine, which has been used for thousands of years for gout, has increased in price from just pennies per pill to dollars per pill as of 2018. And drug prices continue to increase. Just recently, a drug was approved for a certain type of genetic eye disease, and it's going to cost $425,000 per eye, or $850,000 total. Clearly, these increases in drug prices are not sustainable. And you saw the refined belief statements. CalPERS believes in affordability, in sustainability, and yet we also must have high quality and comprehensive care. There's an essential tension between the two sets of ideas, which our speakers today will address. I'd like to introduce our speakers. First, we'll have Michael Zaglinski, who is the CEO of Briova RX. Briova RX is the specialty component of OptumRx. OptumRx is the pharmacy benefit manager for our self-funded PPO plans and certain HMO plans. Next up, Lauren Vella on the PBGH Waste-Free Formulary, an exciting project. She is Senior Director of Member Value at PBGH. Next, Kathy Donison, who is Chief of the Health Plan Administration Division on options for value and affordability. Previous to HPAD, Kathy was with the Health Policy Research Division. And finally, Dr. Jamie Robinson, who will talk about reference pricing as a purchaser strategy for managing drug prices. Jamie is with the University of California at Berkeley. So we'll start off with Michael.
Thank you, Dr. Sun. Good afternoon, and thank you to the board for having me here to speak today about specialty pharmacy approaches to value and affordability. Specialty pharmacy, as Dr. Sun said, if that physician woke up today, would be quite surprised by what he or she would see. And a lot of that has to do with the types of drugs that are coming to the market, the costs of those drugs, and the increased number of people who are having access to these medications. The cost of these medications for pharmacy benefit plans for the pharmacy side of the business are approaching 40 to 50% of the total cost of the pharmacy plan for only about 1 to 2% of the population of people within your membership. The challenge here is that these people who are receiving specialty pharmaceuticals also have many other comorbid conditions. They have a lot of other challenges in their life that lead to issues with adherence and compliance, and as a result, that has a direct impact on their ability to care for themselves and achieve the desired outcomes of the medications. So we are seeing that this is one of the fastest growing trends within pharmacy from a cost perspective as well as an access to care perspective. The traditional approach to pharmacy is generally what is seen from a retail perspective and from a perspective of managing drug costs from a pharmacy benefit management side. And many of those practices that were in place years ago still continue today, but we have to have additional opportunities to manage these costs and also to provide services to the people who are receiving the medications. Whenever I started in pharmacy, I started in home infusion pharmacy in the 90s, and we didn't even have specialty pharmacy as a phrase at that point. And we've seen such an increase in the number of drugs coming to market, especially in the injectable and the oral side, that home infusion pharmacy continued while specialty pharmacy branched off. And we continue to see challenges on both sides, those people receiving infused medications for specialty, as well as those people receiving injectables or orals that are specialty products. We have an approach that we take that is very important from a member perspective that is built upon patient clinical care. And that goes around our ability to have capabilities to provide the care, to manage the costs and the trend, but also to have that care component from a pharmacist or a nurse who is working with patients diagnosed with these chronic, rare illnesses and deal with the issues of adherence and compliance that are unique in the specialty space. Additionally, the ability to take a lot of data, whether the data is coming from the pharmacy adjudicated claim platform, the medical claim platform, lab data, biometric data, self-reported data, is vital to help inform clinicians and have them have more robust conversations with the patient in order to help them achieve the treatment plans that their providers are scheduling and prescribing for them. A couple of the ways to do this that we employ to drive down the costs of health care is, number one, with pricing. Price protection in our contracts with pharma is a critical component of making sure that as the inflation occurs inevitably for pharmaceuticals, that there is control placed via our contracting with pharma in order to achieve a management of the trend. Site of care optimization. As we look at more and more infused medications becoming specialty medications and occurring on the medical side of your plan, the ability to move those members from a more expensive cost site of service, such as a hospital outpatient facility, to a physician's office or to the home dramatically reduces the cost of overall care on the specialty pharmacy side. And lastly, total cost management, not just looking at the ability to keep people compliant to medications, but if they are compliant, what is that doing to the corresponding reduction in costs on the medical side from reduced hospitalizations, less frequent ER visits, and fewer days off from work and a better overall quality of life. Medical benefit management, site of care is part of that. The approach that we take on the medical side is to look at, analyze the data, analyze the claims, determine where the members are receiving their medications, look at the benefit plan, assess the opportunities to take specialty medications that are being infused at a higher cost in another site of service, and working with the provider, the member, and the health plan to move those members to a equally effective lower cost site of care that will reduce costs overall, especially for these high cost specialty medications. As Dr. Sun mentioned, the gene therapy products that are coming to market are extremely expensive. $850,000, as he mentioned, for the new gene therapy to treat an eye disease. While it will cure the disease, it still will be administered on the medical side. So having appropriate management techniques for gene therapy on the medical side so that you are not subjected to higher costs is critical as these drugs come to market, and we employ some of the management techniques that I just mentioned. Our care from a Briova perspective And whenever we are providing care to CalPERS members and our other members who receive services from specialty pharmacy, is primarily focused and centered around the patient. And while that seems simple, that simplicity is at the heart of how we've built our problem, our program, our model, and our service. We are looking at all the data that we have, providing it to our clinicians, and working with them to provide better, more educated care and clinical assessment and follow-up with our patients. We've also provided some innovative tools to your members that allow them to better interact and better manage their care. So Briova Live is our video consult service that we introduced years ago and that we have available to the membership in order to have a video chat with the pharmacist. This past year, we implemented the ability to do an on-demand video chat. So if the member logs into the Briova website or to the app, they could simply click on a button and immediately be connected via video to a pharmacist to have a conversation about their specialty medication. Additionally, Briova Community is a set of videos that we have produced ourselves with actual Briova patients with the conditions. We have 6 disease states for which we provide the videos to the members as they start their therapy with us. There are about 20 videos, 20 to 30 videos per disease category, and it talks a lot about the diagnosis, the drug, the side effects and what to do, how to manage your injection site pain if you have it, and then stories from patients who have the disease just like the patient so that they can understand what to do with other people who go through the same concerns. We've seen over 25,000 patients watch the videos in Briova Community this past year as we added 4 additional disease states in the March-April timeframe. We'll continue to look at additional ways to engage members in a way that they could, on demand, receive the care and the type of information that they're looking for. Lastly, another way that we are looking at how to help manage the cost of these specialty pharmaceuticals is through value-based agreements. I don't think that you can look in the news that comes across any of our desks every day and not see it. In fact, one came across my desk the other day, and the title of one of the articles is Value-Based Contracting Lends Hope in the New Year for Containing Runaway RX Costs. So this is a concept that has been out there, has been in the market, and that we have been pursuing. There are 2 types of value-based agreements and what we are doing. The first is around value-based contracting, which is focused specifically on a drug and the ability for that drug to achieve the outcomes for which you are paying for the member to receive the medication. That is very drug specific and very focused on a specific drug within a category. The next evolution is value-based formularies, where you take those individual drugs but you look at them at a class level, and from that what we're working to do is to provide our traditional benefit design controls but also go one step further to take the value of the products within a category and work to choose the most cost-efficient therapies. So with that, I will end my presentation and thank you and pass it on to Lauren.
Thanks, Michael. So I'm here to talk with you about a project that PBGH is studying. It is very exciting, and I'm really looking forward to talking with you about it.
Ms. Vila, I'm so sorry. Could I ask you to move the microphone just a little bit
I'm
closer
sorry.
to you? Thank you.
So I'm here to talk, way better. So I'm here to talk with you about a project we are studying at PBGH, and we look forward to being able to share more with you as we learn more about the feasibility of a waste-free formulary. So let's talk about a waste-free formulary and why there would be waste in a formulary. Many, many reasons, coming from many different perspectives. So first, we know about rebates. And we know that CalPERS is very likely getting all of their rebates. Great. Many, many large purchasers are getting all the rebates. That's not the case with a lot of other purchasers. However, that there are rebate guarantees in a contract with a PBM will sometimes have the PBM have an interest in choosing high rebate drugs. Even though you're getting the full rebate value back, you might be paying more in advance in order to have a high rebate drug. In addition, PBMs tend to make money off the spread, and so you might know that the spread is the difference between what the PBM pays the pharmacy and what they collect from you to pay the pharmacy. When I say you, I mean purchasers in general. CalPERS agreements might be different, but in general, formularies are built this way. Therefore, there is an incentive to have a higher absolute value spend, because if that spread is 1 to 1.5 points, 1 to 1.5 points of a big number is better for the PBM than 1 to 1.5 points of a small number. So there are these reasons that PBMs are currently building formularies today that are not always consisting of the most high value drug. So let's talk about what those drugs are. Me Too drugs. A Me Too drug is a drug that has, a drug is, let's say, in a marketplace for a while, has done a good job, is a very productive and successful drug. And so pharma might tweak the formula, the tiniest little bit, not an active ingredient, but just tweak that formula a tiny little bit, and that's able to accomplish a couple of things. One, if that first drug was going to go off of patent soon, they now have a new drug that's on patent. The practice is to get patients on that new drug, which is now going to be a patent-protected drug. So there are these practices that are in place. I know you're tracking with what I'm saying here. Combo drugs. Historically, there might be 2 drugs that together accomplish good health for the patient, a good outcome. And it is more convenient to have those 2 drugs put in, those 2 pills put into 1 pill. However, the price point for that convenience might be way more than what you would appreciate if you were made aware of this price point. And I'm not exaggerating when I say many, many hundreds times the price of the 2 pills, combo drugs. Over-the-counter equivalents, having a drug on a formulary when there is an over-the-counter equivalent available, so that the plan ends up picking up the cost of the drug when an over-the-counter equivalent would have done just as well. These are reasons formularies are filled with waste. So, and I apologize, the pay for delay is another important topic, but it's not actually relevant to the waste-free formulary. I'm going to move down to purchaser interest in the formulary the way it is today. Purchasers have gotten what I call the rebate habit. We've become addicted to rebates, so there are many purchasers who love to get that big rebate check at the end of the quarter or the end of the year. Understood. There are purchasers who have programs and budgets built around those rebate checks. But know that almost always the purchaser is paying more in advance to get that check back. But what happens is we get a little bit addicted to that check. When we get the waste out of the formulary, that rebate check will likely go down, but the total cost of care will go down substantially more. Member experience is very important to purchasers, as it should be. So purchasers tend to have a very broad formulary, and they do this because they do not want their members to go to the drugstore and hear that the drug their doctor just prescribed is not on formulary. The way to solve for that is to have a very broad formulary. So we're trying to address that in this project, and we'll talk more about that. Doctors are prescribing drugs without the information, the authority, or the incentive to prescribe the right drug. And by right drug, I mean the most clinically efficacious drug with the lowest price point, the highest value drug. Doctors don't know what that drug is. They have no clue how much these drugs cost. So you can imagine a lot of reasons why there is waste in our formularies today. So let's talk about this little project that we're experimenting with. Press the wrong button, thank you. All right, so here's the project. The project is this. We know, because we've seen it done in a handful of cases in the country, some very successful case studies of purchasers who have taken their formulary, pulled the waste out of it, or perhaps kept the formulary as it is, but applied reference benefit design so that they're not paying extra for those wasteful drugs. Okay, so have a formulary that makes sense, and tell their PBM, administer this customized formulary. We know, because it's been done in this country, that when a purchaser does that, it is hugely successful. And there are case studies I would love to share with you. Many millions of dollars in some cases in savings. So what occurred to PBGH, we work with many purchasers, is why don't we all do this together? Why do we have purchasers out there taking the waste? We all know the waste. Talk to any smart, honest, high integrity clinical consultant, and they will tell you those wasteful drugs. In my conversation recently with a pharmacy manager of a very large medical group in Southern California, she said, oh yes, Lauren, those are the stupid drugs. Those are the stupid drugs. There's no good reason for anyone to be on those drugs. They don't bring any value. They are just very expensive. Why don't we just get them out of the formulary together? Now here's the innovation of this. If we could say to doctors, there's one formulary and one formulary only, prescribe to this one formulary, then we could get doctors prescribing the right drug to begin with. So that whole concern that we have as purchasers about our member experience when they go to the drugstore counter and the drug is off formulary, why don't we address that by getting our doctors to prescribe to the formulary? Now here's the challenge. Doctors today have too many formularies. We've studied this, we've surveyed them. Very difficult for them to pay attention to formularies for every single patient that walks in the door. But if we can partner with our doctors and say there's one formulary, engage them in the process of why we've chosen some of these, to omit some of these drugs, and get them to stop prescribing the stupid drugs. What would happen? Patients are happier because they go to the drugstore, and they will not have co-pays that are ridiculously expensive if they're on a co-insurance plan. Doctors are more satisfied because patients are actually staying compliant with their drugs because they can afford them, and purchasers save money. So, as I mentioned, we're just studying this. This is a feasibility study to see if, in fact, this will work. Here are the 3 questions we're asking. We know this works when it's one purchaser, one PBM. But we're talking about doing it across purchasers and therefore across PBMs. Will it still work? So we're capturing data right now from many purchasers, and we're looking at their formularies and their drug utilization, and we're going to be looking across PBMs because that's where our market is. And our data will be pretty clear if we observe enough waste in these formularies to be able to justify actually going in and trying to remove that waste and creating a formulary without having purchasers change PBMs, which frankly is a big lift, and there are a lot of good reasons for purchasers not to run out and do that immediately. But let's look at we're basically outsourcing formulary design from the PBM. PBMs will hate this, by the way. We'll talk about that more. So that's one question we're going to answer. The other question we're going to answer is, will the physicians, in fact, prescribe to this new formulary? Will they, in fact, stop prescribing the stupid drugs? Now, you understand, when they're prescribing those drugs right now, they don't know how much they cost. So it's not that they're not trying to prescribe the right drug. They don't know. So we have learned a few things. We have learned that they like the idea. They know what they're prescribing is not always the most high-value drug right now. They need to have easy point-of-care decision support to help them know what drug is the right drug to prescribe. And so we're working now with large medical groups to look at how to address that. And the third question we're going to ask is, will employers and purchasers actually adopt this formulary? And so that we'll know when we look at the data, and that we'll know when we find out exactly how much the PBMs will dislike this project, because after all, they make money with the current system. And I think that might be my last slide. I won't go through all these, but happy to talk more about them later.
Good afternoon. Kathy Donison from the CalPERS team. I'm here to talk about the challenges both from the CalPERS perspective as well as the market perspective on how we are attempting to manage affordability and value. On this slide, I want to show you that there are several different areas that make managing a pharmacy program one of the most complicated efforts that I do every day in my job. First of all, there's pricing. It's complicated. It's fractured. When I negotiate a contract, I have to negotiate AWP discounts, maximum allowable charges, dispensing fees, how to dispense as DAW1 or DAW2, trend guarantees, rebate guarantees, generic guarantees. That's just the pricing negotiation. And then there's the formulary, and it is becoming increasingly complicated. Which drugs to put on the formulary, what tier to put on the formulary. We have moved as CalPERS from what used to be a fairly open formulary to a greater customized formulary, and we've had to do that because of the pricing components associated with continual bombardment with new drugs, changing drugs, many of the things Lauren talked to you about. We have worked with 3 tiers for several years, a generic, a preferred brand, and a non-preferred brand. That system is now changing because we have higher priced generics and we have specialty drugs, and you've heard how the cost of specialty drugs are growing. So now one of the strategies is to go to a numbered system for continuing to parse how we pay for our pharmaceuticals. Then there's the new drugs to market, the pipeline drugs. Again, we're being bombarded in terms of manufacturers and what they're bringing to market. And we also have to deal with direct-to-consumer advertising that promotes the Me Too drugs. And finally, there's the black box associated with medical pharmacy. There's no common coding structure. We have various places where the same drug can be administered, and just simply based on the site, do you have a higher cost associated with the very same drug? That little black box over there, that's purchaser frustration, and that's lack of transparency. And then you can see the little shell game that we play in terms of these components. We have non-transparent supply chains all the way from the manufacturer to the point of sale, either through the mail or the retail or as the specialty pharmacy. There are costs associated with the supply chain. The cost is that we get these new pipeline drugs and we don't know how they were costed out and what brings them to market with that cost. Every time you have a high-priced drug release, such as Hep C, there's an access problem. And there's also a short-term problem in which our premium trends are driven. Then you have the EpiPen situation. EpiPens, we studied epinephrine in biology and biochemistry when I was a student. It is not a complicated molecule, and it shouldn't be so expensive. Access, when you price to what the market will bear, it affects access. The manufacturers, that is probably one of the biggest black boxes associated with transparency, and why do they choose to make a drug, and when do they choose to release that drug to the market? And then you have the manufacturer contracts in which they are promoting patent extensions. They will develop a drug, they'll release it for adults, and then they'll make it a pediatric, and then they'll start all over with patent protection. As Dr. Sun said, colchicine is a DESI drug. When I was in the clinical practice back in the mid-70s, colchicine was treated for gout. Some of these drugs have not gone through FDA approval because the FDA did not exist. So as these drugs then get put through the FDA approval process, it's an opportunity for manufacturers to then increase the cost of the drug. There are quotas on production. You can have OxyContin produced for 6 months and then not produced for the next 6 months, which becomes a shortage. That actually, not OxyContin itself is the shortage drug, but that is a problem in hospitals. What do you do when the drug supply runs out and there's only one manufacturer that's making it? And then there's the market. The market itself is very non-transparent because, as it seems to all of us, the market tends to simply reflect, due to lack of transparency, that some drugs are simply priced to what the market will bear. So I want to tell you about some of the strategies that we're looking at. It's not going to necessarily address the transparent supply chain, but these are the strategies purchasers have to bring to bear in order to manage the lack of transparency. One of the things that I'm going to end is talking about reference pricing by therapeutic class and then hand it off to Jamie. We can go to group purchasing. But some of the other strategies that are happening are the narrowing of the pharmacy networks, narrowing of the formularies, utilization management and prior authorization becoming more stringent. We have taken steps by bringing forward multi-source and single-source equivalents and alternatives. That has been a good strategy for us. We are also looking at what the value-based purchasing, not just for the non-specialty reference pricing, but there's real hope that with the ICER model, which Jamie will also talk about, that we can take a value approach, which is cost and quality, and value-based pricing those specialty drugs. We are also looking at academic detailing. And I'm very pleased that under our current contract, we are now putting forth efforts that we are going to start sending out physicians to physicians to talk about price. The doctors simply do not know how much the drugs cost that they're asking the members to pay. Now I want to talk about some of the strategies I'm going to be speaking to you in the next 6 months about implementing for CalPERS. One is to implement a reference price by therapeutic class. This has been shown to be not just cost effective, but actually to simplify the complicated system I've just described. Under a reference pricing approach, we may be able to get away from some of these complicated utilization management programs, such as members pays the difference, and simplifying or streamlining the prior authorization process. Value-based contracting. We have that ability to do that in the contract, and we are working with OptumRx in order to make some strides in that direction, where if the drug does not deliver the outcome that's expected, then we can go back to the manufacturer and ask to be paid back for that purchasing effort. We are thinking about redefining the tiers to numerical tiers, and Blue Shield wants to take that approach. Blue Shield manages its own pharmacy, as does Kaiser. I'm not sure yet about whether that's a good strategy. We as a team will continue to explore that. We do need to reduce the administrative and formulary complexities within our program. And so as we look forward to talking to you as a CalPERS team and going forward, these are some of the things that we will be presenting to you. Now, why not a narrow network? Why not a narrow formulary? We will also bring back the reasons why we may not recommend that approach. We see some of these things as simply workarounds in a very complicated system and market. I want to talk about the importance of our partnerships. This slide came up when you had the presentation on opiates. Opiates is a way that we have 3 agencies that are sister state agencies working on the problem: CalPERS, Medi-Cal, and Covered California. We believe that our sister agencies, we can continue to collaborate and move the needle forward for all of us, not just CalPERS. Then you have the California Collaborative. These are the sister agencies that actually have to directly buy pharmaceuticals. We have joined with DGS and the Department of Corrections, and while we may not directly purchase, we want to support our sister agencies that are dealing with the very same issues we are. And then there's the importance of both local, statewide, and national strategies. Public and private purchasers are coming together. I get called now from the New England states, Colorado, through these business groups on health that are similar to PBGH. They're calling us up and saying, what are you thinking about? This is what we're thinking about. We also need policymakers to be seriously considering about some of the issues associated with the transparency, associated with the markets, and to also be strategizing about ways to make the supply chain more transparent. Our providers, they do not understand that the drugs that they prescribe aren't affordable in many instances. We need to work with our providers more closely. We need to understand technology, why drugs are developed, manufactured, and why they come forward to market, and when they're released to the market. So we need a collective associated with all of us working together to manage, I think, the issues associated with cost and with affordability and availability of pharmaceuticals. And then finally, there's the ICER approach. And I'm not going to spend a lot of time on this slide. We're only just now looking at it and exploring it. But it is a value-based purchasing or reference pricing approach to specialty drugs in which a reference price is set under the ICER model that takes into consideration both cost and quality for specialty drugs. And that's how CalPERS has traditionally defined value. It takes into consideration cost, quality, and evidence. Thank you. I'm turning it now over to Jamie.
Thank you, Kathy. First of all, I want to say how much I appreciate being invited to speak to you today. And then more generally, the University of California, have had it now for about 10 years, a research partnership with CalPERS, and I've worked on a variety of projects with both the board members and with the staff. It's been great, and done the studies, particularly of your reference pricing initiatives around joint replacement, around ambulatory procedures, and I'm currently doing two projects with you. One around physician-hospital integration and the implications of that for pricing and the market performance in California. And secondly, I've been asked to look at potential savings in this moving to a therapeutic reference pricing for drugs for CalPERS, and that's what I'd like to do as part of our partnership. I'm going to be talking about two strategies that have been used and are being used in the marketplace, one addressing non-specialty drugs and one addressing specialty drugs. What is a non-specialty drug? Non-specialty drugs are the traditional drugs where you go down to the drugstore, you pay 10 or 20 bucks, you take this thing home, you put it in your mouth, that kind of drug. That accounts for about 2/3 of your spend. That's the most drugs, most common, but each drug itself is relatively cheap. Specialty drugs are the expensive drugs. Some of them are oral, they're injected or they're infused. They account for about 1/3 of your spending. This is all the innovative drugs, cancer, rheumatoid arthritis, orphan drugs, et cetera. And so I will be talking about them, each of those separately. Okay, so first I want to talk about reference pricing. Reference pricing is, as you all are experts in it on the facility side, but on the drug side, it really boils down to drugs being sorted by their therapeutic class, because there's multiple, for non-specialty drugs, multiple drugs that do essentially the same thing. And then the payer sets its contribution at the level of the cheapest or one of the cheapest drugs and tells all the employees and the physicians which ones are those, so to move the prescriptions to the cheapest drug. If the patient wants a more expensive drug that is no better but is more expensive, they pay the difference themselves. So it's there's a choice element to that. The patient does have the ability to choose the more expensive product, but there's always a cheap product with a $10 copay, $10 per prescription copay. So I did a study of this. This was implemented by the Rita Trust. Rita Trust is a national association, purchasing association of Catholic dioceses that buy insurance for their employees, mainly school employees, Catholic school teachers and other employees, plus nuns, priests, other people who work for the Catholic family. And they implemented reference pricing. And so we did a study somewhat similar to the ones we've done of CalPERS, looking at the change in their utilization. Do consumers actually move to the cheaper drug when they've got the incentive? And then to the extent that they do, what is the reduction in the actual price paid by the Rita Trust, or in your case would be CalPERS, and then the effect of that on the co-payments by the patient. And so we found that, and we use as control group data from Anthem Blue Cross, which has not implemented reference pricing for their larger California membership. So I just want to give you just briefly, this is the blue line is, so what these lines represent is the percentage of prescriptions which are filled within a therapeutic class for the cheapest drug, for the reference price drug. And the blue line is CalPERS members, and the red line is the Anthem PPO California membership. Okay? And so this is between 2011 and 2014, 2015. And what you see is that there's essentially no change in the red line. It just is about the same over time. The CalPERS has always been a very generous employer coalition, and so their members tended to use more expensive drugs. But then when reference pricing was put in, you really see a jump in the percentage of CalPERS members that choose the cheapest drug within their class. The effect of this on pricing was, once again, the blue line goes down. That means CalPERS, I'm sorry,
Just to be clear, Rita Trust, right?
Rita Trust, I'm sorry.
Yeah.
This is all Rita Trust all the time until it's not. So Rita Trust saved 14% on the price of these drugs, mainly by moving market share to cheaper drugs. Rita is a much smaller entity than is CalPERS, and so we not expect any response on the provider side because they didn't notice. It's a small, but they save the money just because their members switch to the cheaper drug. We're now engaged in a larger study looking at a variety of labor union, health and welfare trusts, and employers who have put in reference pricing nationally to see how this works in different kinds of subpopulations who are not necessarily Catholic, although they might be Catholic. All right. So now the question, I want to move now to specialty drugs. The key of reference pricing is that there's multiple therapeutically equivalent drugs for the same condition. That's the case most of the time in non-specialty drugs, all right? But in specialty drugs where we have all the innovation, the new drugs typically are different than and often incrementally better than the drug that's been existing on the market. So what are we going to do about those? You can't just say we're going to pay them the lowest price in the market because they're better. They are better. The underlying principle is the same. The principle of value-based pricing is as follows, and everybody uses the term value-based pricing, and so it's been overused. I've got a new term for it. It's called blockchain-based pricing. You've heard it here first. By the way, I work with Lauren Villa on this stuff, so the PBGH. So the basic idea is, see, a drug price functions does two things. A drug price reimburses the drug company for the cost of manufacturing, distribution, and general overhead to stay in business, plus it rewards them for innovation and allows them to continue the innovation cycle. Now, if that's the case, then the principle of value-based pricing is if a new drug comes on the market and it offers no incremental benefit over an existing drug, it should not be paid more than an existing drug. This is reference pricing. That's called reference pricing. But if it does offer an incremental benefit, it should get paid more. The question is, how much more? Okay, and that's ICER-based pricing. So I am engaged, in addition to more work on reference pricing, on a project around value-based pricing with PBGH and others, and with ICER. Let me say a word of what is ICER. ICER is a not-for-profit think tank. It stands for the Institute for Clinical and Economic Review. And ICER and its network of scientists and physicians and pharmacists does comparative effectiveness analysis of new drugs, of new specialty drugs, cancer drugs, genetic therapies, autoimmune drugs, the expensive drugs, the stuff you read about, and compares them on all the, goes over all the FDA literature and all the other literature on the effectiveness and the risks of new drugs compared to the closest comparator drugs that they are in their same therapeutic class, and identifies the differences. Typically, there's multiple different aspects of a drug. It might extend life more, but the quality of life may be less, or it might have adverse side effects, or it might work better for some patients than for other patients. This stuff is complicated. And so what ICER's in the business of doing, and its funding comes from charitable foundations for research foundations, is to quantify all that and come up with what it considers to be and this is all transparent, it's all on the web, it's methodology, and it has patient advocacy panels that do help them with this. What is price benchmark for each drug? In other words, what is a value-based price, an actual dollar number for each new drug? And these benchmarks, our project that we're involved in is how to use these benchmarks in actual negotiations with the drug manufacturers. Trust me, these benchmarks are usually much lower than the prices posted by the manufacturer. You can just trust me on that one. All right. So we're talking about meaningful rebates, but our project is about if certain manufacturers will reduce their price down to that level, will the payers reduce the prior authorization and step therapy and obstacles for the patient so that we can have both lower price and lower barriers to access? That's the crux. Right now, America, we've got the worst of both worlds. We've got high prices paid for by you guys, and we have high access barriers which prevent the patient from getting a lot of these drugs, and the doctors going crazy because of prior authorization obstacles. Doctors are pulling out their hair. So that is, and by the way, this came in too late to be in the thing, but I think you've got a paper copy of this, and I just want to just run through this very briefly, and you can take this home and you put it under your pillow, and so that you will learn it overnight, okay? So new drugs go through an evaluation up in the upper left, assessment of the new drug compared to the existing drugs in its therapeutic class. If it has no incremental value, it should go to reference pricing. In other words, it should get paid. You all should be willing to pay the lowest price of the other drugs in that same class, but not more. If it does have benefit, it goes to what we call value-based pricing, or I call now blockchain-based pricing, which is that it's negotiated a higher price than the existing in exchange for lower access barriers for the patients and for the doctors. And thank you, and I'm happy to answer any questions about that as we go on. Thank you very much.
Thank you. Dr. Sun, do you have any wrap-up comments before I open it up to questions?
No, I'd just like to thank all our panelists for speaking today. And now I'll turn it over to Ms. Mather and the board and the executives for any questions or comments.
Thank you. Well, I think the panel has raised a number of really interesting ideas for us to consider, and we do have several questions. Mr. Slayton, you're first.
Thank you, Madam President. Thank you all for your time here today. This is probably one of the toughest issues that we continuously face. Maybe you could address, and it was mentioned, Kathy, in one of your slides, you know, if you watch cable television, most of the ads on it end with the expression, ask your doctor. And I presume that many of these are these add-on drugs that just slightly change things, and yet the pictures look wonderful. And so the pressure that's on physicians coming out of that advertising, is there any initiative to treat those ads like we treat hard liquor ads on TV, which are not permitted?
It used to be treated that way.
Well, yes, but it's going to take all of us. Academic detailing is a way, we think, that we can push the needle to start to get doctors to understand what it really costs. But let me give you some background on detailing itself. This is where the representatives of large manufacturers come into the doctor's office and say, look at this really great new drug that we have. And then so they go to the doctor, we got this really great new drug, and then the patient member goes in and says, gee, I saw this on TV and it looks like it would be something that would work for me. There is a lack of information both for the member, like Lauren said, could just be a Me Too drug. Is it really necessary? And two, for the physician, they may not understand what it takes out of the pocketbook of that patient in order to prescribe that drug. And then I'd like to ask Lauren or Jamie if they want to say anything.
By the way, after you actually listen to one of those ads, when they talk about the side effects,
Yes.
I don't know why one would ever ask for that drug.
So we see academic detail. So the notion of academic detailing is that there would be a clinician, a non-pharma sponsored clinician, educating physicians about the holistic picture of that drug, not just the great clinical benefits, which is what they do now, but also the value proposition of the drug, and that this is why this drug is just as safe, and by the way, did you know it costs this much? So we think of academic detailing. Actually, PBGH is about to embark on yet a parallel project to study academic detailing, and I'm really excited because we need to talk about that. So academic detailing is a really big ad and a way to combat. I did one time ask a colleague about on television promotion of drugs, because I actually do, my gut tells me it's just a really big problem, and when you talk with doctors, they get hit with this all the time. And honestly, as I understand it, there have not been a lot of studies done on it, or is there any hope that it's going to go away? The only studies that have been done have been pharma, and they kind of believe that, you know, it's not a problem, but they're sponsoring the studies. So I agree with you. I think it's a challenge.
I'll make a comment. I think the earlier discussions you had before lunch was when you're trying to combat inefficiency in the healthcare system, one tool is price transparency, but transparency by itself doesn't have that much of effect if there's not an incentive latched to it. And what you've experienced with is transparency plus reference pricing has been more effective than transparency alone. In the drug world, the analogy to that, I'm going to just take part of the drug world, which is the medical benefit drug. In other words, the drugs that the physician directly administers in the office, either through infusion or injection. And on those, historically, the business model was that the doctor bought the drug from the distributor at one price and then would charge the insurance company a much higher price and made a lot of money, and so therefore the more they prescribed, the more money they made. That is changing, and one of the things that's going on out there, and with a program pioneered by Kathy and Anthem, is to move that medical infusion from the hospital-based clinics, which are the most expensive, to either physician office or home infusion. And so it's partly to reduce that markup and partly to get them to choose the cheaper drug when available. And now we have, in a lot of those infused classes, multiple therapeutically equivalent drugs. So there is choice because of all the new drugs coming down the line. So it's an example. So it's education, academic detailing, plus incentive.
Thank you.
As I recall, we didn't have drug advertising 20 years ago. I think that was under the Clinton administration that it got reintroduced as, or permitted by the Senate, by the Congress. Okay, let's move on. Mr. Jones, you're next.
Yeah, thank you, Madam President. My question is for Ms. Vila. Mm-hmm. At our November Health Benefits Committee meeting, one of our members spoke to the board and also made reference to an article in the LA Times regarding clawbacks. Mm-hmm. Provisions. Mm-hmm. And in your presentation, and by the way, we raised the question with our pharmacy benefit manager, and we were assured that that's not the case. But when you made your comments about the spread, mm-hmm. In your comments, you said, mm-hmm. well, they would choose the higher price to get a larger spread, but isn't that a clawback through the back door? Mm-hmm.
It's a little different than a clawback. It's very good, and there's so many other things I didn't even talk about. It's such a complicated business model, the way PBMs get paid. However, it's a little bit different than a clawback. So a spread it's an acknowledged way that the PBM says to the purchaser, and again, I'm not really speaking specifically about CalPERS contracts, which might be different than the average purchaser, although this is the general business model, where the PBM says to the purchaser, look, you don't have to pay me an admin fee or a very high admin fee. In exchange, know that I'm going to keep a little bit of the, you know, I'm going to make a little bit of money from the pharmacy on this drug. That's kind of the concept. But really what's happening is the PBM pays the pharmacy. Let's say the PBM is paying the pharmacy $20 for the drug. Now, doing that on behalf of their self-insured plan sponsors, right? So they go to their self-insured plan sponsor and they say, okay, now you owe me $22 for that drug. but they paid the pharmacy $20 for that drug. So that's $2. It's not very much. It's, 1 point, right? What is that, 10?
You said 1.5 to
One
1
and a,
point.
it's like 1 to 1.5. None that my math did not work there, but you're with me. 1 to 1.5%. So obviously they want to have a high absolute value because 1 to 1.5% of a big number is a better thing than 1 to 1.5% of a small number. A clawback is something a little bit different. It has to do with the benefit design, where the drug cost might be less than the copay. And the rule, the clawback rule, is that the patient pays the copay, which let's say for some employers might be $15, pay the $15, but the drug costs $7. The pharmacy was not allowed to say, oh, you only have to pay me, here's your $8 back. That the pharmacy kept that $8 and it back to the PBM. So that's a kind of a different concept, but it is another problem.
Yes, it
Yeah.
is.
Yeah.
And so is there any effort to deal with that problem in the
So the
industry?
formulary will not specifically deal with that problem. Better transparency in our contracts with PBMs will deal with that problem, and also benefit design, smarter benefit design will deal with that problem. But I don't think my project will deal with that problem directly. I'd have to think about that for a minute.
Thank you. Mr. LaFaso.
Thank you, Madam President. Not my question, but Ms. Vila, I don't know, somehow in my simplistic brain, your answer sounded like the concept is a simple percentage-based markup. But that's not my question. My question is for Mr. Zaglinski. I hope I'm allowed to ask this question, but what are our own PBM's thoughts on the waste-free formulary and all those concepts about minimizing rebates, et cetera, that Ms. Vila talked about?
So we have a full intention of working as well with PBGH or any other group that's out there to minimize waste in the formulary. Our goal is to provide the best, the lowest, the broadest, the most comprehensive set of drugs on a formulary that is best for the members and per the pricing with CalPERS or any of our clients to provide the best formulary options. We customize formularies. We provide options for our clients based upon their own unique configurations and needs for their members. So we welcome any opportunity to further develop formularies that, to Ms. Vila's presentation, further drives out waste in the formulary.
Thank you. Ms. Taylor.
Thank you. I want to thank the panel. I think you guys did a great job of explaining how we can sort of get through this morass of pharmacy formularies and waste. And so, but I had a specific question, and it sort of goes back to what our workshop was this morning when we were looking at one of the specific aspirational goals. And Kathy, you had talked about it in, hold on, let me get to that page. It's here somewhere. There we go. Importance of national strategies. So I understand we're working with partners right now, and PBHC is one of them, or PBGH, I'm sorry, is one of them. We also have Smart Care. We have Medi-Cal Covered California we're working with. We're the second largest purchaser of healthcare in the country. Are we looking at a national or a federal legislative strategy to start containing pharmaceutical costs because everything you're describing sounds to me like it didn't used to exist, and it's gotten worse and worse and worse and worse, right? So it sounds like to me and I don't mean to offend anybody, but it sounds like the pharmaceutical companies are taking advantage of our consumer-based and profit-based pharmacy that we have here. And I'm wondering if there's a way that and this environment we're in right now, I know isn't open to that, but at some point, should we not be looking at legislative fixes, federal legislative fixes to control the pharmaceutical industry?
That's a tall order to answer, but I do want to start with the national level and simply say pharmaceuticals are national and international. And if you look at how much we spend on the very same drugs in comparison to other Western countries, we're actually it's kind of a cost shift on a global level. So that's a problem. I can't tell you that we can tackle it today, but it is something to think about. How do you take a national set of problems, and I really direct it back to the lack of transparency. So you've got lack of transparency in the entire supply chain, and then you have national, what we described at the local is also at the national level. So that's all I can really say about it, because I think that's where this board, under your leadership and our president, may want to think about what that future will lead and what you want that health belief to be about. So what we can do is what we are doing. We work with our sister purchasers across the United States. We work with our state and local policymakers to say, what can California do? I think that, though, in order to develop either a local, state, or federal strategy, we've got to have the transparency that's lacking, because we don't know what the root cause is. And there's a lot of finger-pointing going on between the PBMs and the manufacturers and the Pharmaceutical Manufacturing Association, and trying to tease all that out and figure it out. That really is, I believe, the future direction that the strategies are going to have to take. The ones that I described, to me, are just continual workarounds, and all they do is complicate my life and your life and our members' lives. It doesn't get to the real heart.
Kathy, how do we get to transparency? I mean, we talked about a lot of different strategies around how to get to transparency, but is that also a federal legislative
No,
issue?
I think our state did with SB 17. I don't know what it means yet. I'm starting to
I don't
get
either.
notified, but I have to kind of see what my notifications say in order to know kind of what would we do with the information and what would be our next steps. We have made, I think SB 17 was a really good step in the right direction. So.
Okay. Well, hopefully it is. Thank you.
I'll make one,
Thank
if I make a comment on that. One aspect of transparency in the pharmaceutical domain is simply understanding how one drug relates to another drug. Because if you're a purchaser, you want to go for the lower price, you really care about the
Right,
difference.
and that was
And
part of
that
this, yeah.
is something that there is a public policy dimension of that to promote and reduce the barriers to what we would call comparative effectiveness analysis. And that is something that is part of a policy agenda as well as a marketplace contracting agenda.
Okay.
Thank you.
Sure.
Yes, please.
So I did just want to know, because you mentioned, that the pharma manufacturers are doing this, and I think the system has become so muddy that, and I do I agree with you. It sounds like it's gotten so, we finally have hit a tipping point, which is now not sustainable, and now we're paying attention and we're seeing that the system has become so muddy. It really is not just pharma. It is the PBM, and everybody has their hand in this pot, and that's why it's a little bit difficult to unravel. But I say the most important thing we can do as purchasers is stop paying more than we should for a drug for which there is a therapeutic equivalent that costs less. If we stopped paying for those Me Too drugs, those combo drugs, those over-the-counter equivalents, the manufacturer would no longer have the incentive to manufacture them. It would be like, why would they manufacture something that no one is going to buy? And it's irrational for people to pay so much more for those drugs that are not adding value. We need to stop doing that. They will stop supplying them then, and the PBM will stop. The PBM will not be able to make so much money off of that stuff. So we'll have to have a little bit more transparency, because the PBM will have to start charging us a fee for the service they provide, and therefore we can make a value proposition and pay them appropriately for that service. So if the PBM is going to be adjudicating claims and doing clinical care management, let's say that's what they're going to do, then we can pay them an amount of money equal to the value of those services, and in fact we can comparative shop those services. But right now what we have is we don't actually even know how much the PBMs are making off of us because of all of these revenue streams that are hidden. So it's really impossible to do comparative shopping or to know whether we're paying a fair value for their service. So I think that when we start to create a market that makes sense by not paying too much for these products, then we will have those other services line up and start making more sense also.
Thank you.
To add to that, I just want to, because you triggered something in my head there, the fact that it's a market-based system has added this layer of too many people with their hands in the pie. So, and that's another issue. So I don't know how we even resolve that. But yes, if we have more transparency, I can see how that can be resolved. But if you're talking about it's not just the pharmaceutical companies, yet we still pay the highest price of any westernized nation for pharmaceuticals, but then we have so many different hands in the pie, and I think that really has disadvantaged us to such a great degree, and I've never seen it this bad. And even when I first joined the board, it wasn't this bad. That was 4 years ago, guys.
Yeah.
Thanks, Ms. Taylor. Ms. Brown.
Thank you, Madam President. Just to comment on Teresa's comment or on your comments, as someone who started out taking imatinib from Novartis at $3,300 a month in 2009, now to $14,400 a month, and now they want you to switch to the Sun Pharma generic. It's pretty darn scary to think about switching to the generic, since that other drug, the brand name drug, has kept you alive all this time. So while you try to be rational and think about this, it's pretty darn hard to switch. And this is a question from our members, and it has to do with Optum Rx. And so how does Optum Rx make the determination that new-to-market generics are truly effective without side effects as the brand name? And also, again, members do report side effects from taking a generic, whether it's placebo or not. And they're also worried that, will the generic actually work as well? And then the second part to that question is, does Optum Rx use the ICER formulary for its development?
Thank you. So for what we do at Optum Rx, first and foremost, every drug that comes to market goes through our Pharmacy and Therapeutics Committee review. This is a panel of external physicians and pharmacists and experts that review each drug as they come to market. They review the differences in that drug, what it offers clinically, and how it might meet or not meet the qualifications to be on the formulary. As new generics come to market for drugs that are existing, those generics have to pass certain toll gates to be approved by the FDA, and once approved and designated as an approved drug, then it will be identified as an opportunity for us to offer to our clients that there is a new generic. The generic has been proven and tested to be effective and to be safe, and as such, it will be included on the formulary if it passes the criteria. Whenever there are issues, however, that might come up with a specific drug where a member may have an issue, there is always an appeals process, and there's always a process for our clients that set the process to go through, that if for some reason the member needs to remain on the branded drug versus the generic drug, then we work with our clients to determine how to handle those specific situations on an exception basis.
And I'm new to CalPERS, so do we have those in place now? Yes. Yes. Thank you.
Thank you. Mr. Juarez.
First of all, let me...
Can you make sure your microphone is on? Thank you.
Here it is. First of all, thank you, Madam President, and thank you to the panel. I just was so impressed with each of you had something to offer that was seemingly going to put us in a better position than we are today. My question revolves around whether or not they're all mutually inclusive, if I can use that term, that nothing that you've heard today would obviate or work against other proposals that you've heard from the other panelists. And that's a question to each of you, that I guess what I'm asking, can we do all these things as additives and get to a better place?
Maybe I'll start and then pass down the list. I think that everything that's been discussed today absolutely can be done. There's not something that is mutually exclusive from the other. Even though Ms. Vela may have a particular opinion about how things are done within PBMs, we have a very specific contract with CalPERS. We have audit rights that are extended to you to look at what we have set up with you. We have gone through a stringent procurement process to become the vendor for CalPERS. And we, as I said, we are always willing to work with any of the panelists and any of the board members or members of CalPERS to further improve what we are offering to the CalPERS members.
I think it's an excellent question. I was thinking it as I was sitting here that it's great news that we do all fit together. So the waste-free formulary that I described is only applicable to those drugs for which there is a therapeutic equivalent option. And then when there are these therapeutic equivalents, you want to make sure you're paying for the higher value. So a lot of the specialty drugs that are being well managed by Michael would not fall into this waste-free formulary conversation, because so often the specialty drug is a very, it's a very unique, I was going to say molecule, but it's even a biologic. It's a very unique formula, and there may not be a therapeutic equivalent, or it may be too soon to know there's a therapeutic equivalent. So and even if there are therapeutic equivalents within the specialty space, and actually in some cases there are, even in those cases, those patients need to be very highly managed. So you need to have clinical case management involved in those cases. And then the other thing I would say about a waste-free formulary, and I know Jamie's going to talk about this as well, but I could not stress it enough. A reference-based benefit design is the perfect benefit design for a waste-free formulary, because you're not telling anybody they cannot have that more expensive therapeutically equivalent drug. You're just saying if you'd like to have the more expensive therapeutically equivalent drug, then you'll pay the difference. So I love reference-based benefit designs as a complement to this program.
I want to agree with both of my panelists. Nothing in here that we have presented is mutually exclusive. However, we do have to, from my perspective, look at what is just one more workaround for greater complexity, and how much administrative expense or burden do I have to bear as a program manager. So I look at those things. I look at, it's been presented, and I will eventually present it to you so that you can decide yourselves, but I believe narrower formularies is not the best answer. That's why I like the reference pricing and the waste-free formulary. Narrower pharmacy networks, I think, is fraught with some hazards associated with, one, is that getting to the point of dealing with the market, or it's just one more, even more complicated workaround. So no, none of these are mutually exclusive, but I think you should be prudent in what you think you should do or not do, and that our job is to bring those forward over time and let you decide. As I said, should we have numerical tiers instead of these word tiers? Definitionally, it makes sense, but again, you're just continuing to parse drugs into different cost buckets without really kind of getting to the root of why those costs are associated with those drugs anyway. So I believe that what we want is simplification. We want to work with our sister states, our sister purchasers, and I think there are two levers that we can pull, and I think the panel will agree, and that is the reference pricing by therapeutic class, and continue to explore the ICER model as the direction we want to go in terms of dealing with cost and quality, with the value component associated with specialty care. Jamie?
And I'm just going to echo all that. I think that that there's like three criteria. One is, don't try to do everything because it's too complicated and too administratively burdensome. Of those that you choose, the criteria should be pick strategies that have a tangible, you can taste it, savings within a few years, kind of confidence building. And thirdly, strategies which over the little bit over the longer haul help educate the membership that's out there that Drugs are valuable if taken appropriately, but there are a lot of choices, and those have a lot of financial implications for the member, but also for the whole trust for the employee, and that they should be savvy about that. We want to culturally change that gestalt of the patient, to not be, well, whatever I saw on TV or whatever my doctor prescribed, but rather that stuff's okay, but I also want to think about the comparative clinical benefit of it and the comparative price of it. And so we want to train that. So simplicity, short-term savings, long-term culture change.
Thank you. Thank you. Mr. Miller. Could you turn the mic on?
There we go. This kind of piggybacks on a lot of the other questions and comments, but one of the concerns I have is a lot of this seems to put quite a bit of the burden for some complex decision-making on our members. The idea that these kind of financial incentives, aversives, will cause them to make the right choice, which the cheaper choice, when things may be clinically kind of equivalent, but they are different. They're not identical. And so what are your thoughts about striking that balance of how do we also, beyond just giving them information, get the clinicians to play more of an active role in guiding our members to those decisions? Because for a lot of our members who are on a fixed income, who are living on a meager pension, and look at, that difference, I'm just going to go with, whether it's one choice or two, or whether we have ultimately a more complex tiered system. They're not clinicians. They don't have that information. Their time with the clinician is somewhat limited. And so how do we get the clinicians, how do we balance having them step up their game? What's in it for them to step up their game and help with those decisions versus just trying to use the leverage of the dollar to push our patients, our members, to a lower cost alternative?
If I may start, I think one of the things that we had provided via our CEO, John Prince, at one of your prior meetings was the concept of moving the decision-making further up into the process, to your point, where the physician, the provider, has more information at the point of prescribing versus waiting until the prescription goes down the road to get a call or a reject or a request for information when they could have made a better decision up front. So we've been implementing Pre-Check My Script, which is the ability to integrate with the EMR in the doctor's office and offer the doctor information at that point, whether that is there are other alternatives. There are alternatives that do not require a prior authorization. There are lower cost alternatives for the member, and allowing the doctor to have more information to make the decision with the patient in front of him or her versus waiting until this feedback loop occurs and the delays that we currently have as a system in pharmacy today. We implemented this last year and will continue to expand it to multiple EMR vendors. And I think that that is one of the ways to address your question, which is give more information at the point where the physician can make a difference in a decision at that time.
So this notion of having the physician engaged by prescribing the right drug to begin with, it is really at the heart of our project, because it's just better all the way down the stream if the doctor prescribes the right thing to begin with. But what we now know is that the doctor does not have the information, the authority, or the incentive to prescribe the right thing. So we're trying to address all three of those things. And it's very important that we think about the incentive, the authority, and the information. So the information is what Michael talked about, which is point-of-care decision support. We're doing a lot of thinking about what it would take. Integration with the EMR is a very important thing. One spot to go for all the PBMs is a very important criteria. Having the information in a user-friendly, all that stuff. Okay, point-of-care decision support is really critical. That gives them the information, including the plan sponsor price of the drug. That's a critically important part. It's great to know that your patient's only going to pay $10, But if they're going to pay $10 for both these drugs because of the way the benefit design is set up, and this drug costs $1,000 and this drug costs $15, we have doctors telling us they'd like to know that and that it would influence their prescribing. And then we also need to think about the incentive. Doctors are increasingly taking on some accountability for total cost of care. That should include drugs, but they can't do that until they have the information and the authority to do the right thing. And the authority is for the doctor to be able to prescribe what he or she thinks is right for the patient and not get, Jamie talked earlier about doctors pulling out their hair with the pre-authorization protocol that's in place by all the different PBM. I mean, it's a very big problem and frankly nonsensical that depending on where the patient gets their insurance coverage, they may or may not be able to access a certain drug. I mean, we have to really get to the place of giving the doctor, having the doctor be the focal point, but giving them the information and the authority and the incentive to do the right thing. And all of these efforts are just efforts to work up to that.
Thank you. Mr. Slayton.
Thank you. So, building on what you just said, another lever, the Kaiser Family Foundation in their study September 2016 said that 82% of the public wants to give the authority for the federal government to negotiate drug prices for Medicare. So, first of all, if that authority ever comes in, what's the impact on us? And do you see that as a viable way to start bringing the costs more in line?
I do, but I would say yes. That's good.
Bit of a crack at it. I think that actually was one of our federal initiatives some time back. It was actually on the list of things that we wanted our federal representatives to continue to look at and to advise this board. It goes to the federal policy level I was speaking to, and I think that's one of the levers that could be pulled in the future. I don't believe it has any impact on us so much as that it would, under the Medicare Part D program, perhaps get us some price relief in terms of the amount of money we pay for even the employer group waiver plan members. We just presented that information to this board a few months back. So I think it helps us in terms of they're paying for it, but we're also paying for it.
So is there such a thing, and I understand that, we're talking about Medicare and not necessarily our plan our actives are on, but is there such a thing as most favored nation clauses in this particular arena? And therefore, if Medicare negotiates lower prices, doesn't that ripple through the entire system?
Well, if I may say, there seems to be two different questions going on. One is, if Medicare gets a better deal, will that mean that the drug companies will end up charging everybody else more? The sort of the cost shift question. Let's put that to one side. And then the other complexity is, well, what would Medicare price negotiations actually look like? And that is a wonky question. On the Part D drugs, they already do negotiate because it's the PBMs that run that, and they already do their thing. On the Part B infused drugs, they don't, and that's actually where there's some really creative thinking happening, and that is where, once again, to negotiate prices, as a purchaser, you need two things. First of all, you need choice among alternatives, because if it's a monopoly product, you're not negotiating anything. And then if there is multiple products, you've got to be able to say convincingly how similar and how different are they, because otherwise, the drug company will always say they're unique. Okay, you can count on that. So those two components, which is what we've been talking about, really carry right over to Medicare. If they want to do negotiated pricing on Part B, they're going to have to do comparative effectiveness analysis, and they're going to have to be willing to have some form of, call it reference pricing, call it what you will, to say we'll take this drug instead of that drug because this drug gave us a bigger discount. And so those issues will crop up.
Thank you.
But the favored nation pricing that you're referencing, Medicaid has preferred pricing, right? And there's a whole lot of challenges around being careful that pharma has to be very careful not to go under that price for any reason. So whether it's negotiation or whether it's value-based contracting or for whatever reason pharma might find themselves paying under that price even for one drug, they have to be very careful about that because by statute they cannot charge less than what they charge Medicaid. So if they do, then they have to go down and pay
Redo their
Medicaid
pricing.
less. So it is a complicating factor when that is in play.
Thank you.
So one of the questions that Mr. Slayton raised in the context of our opioid conversation was the quantities of prescriptions, not for maintenance drugs, obviously, but for occasional use or acute incidents. And are any of the strategies that you've talked about, are any of those looking at that and reducing the quantities of a particular drug that might be prescribed?
So we introduced our opiate program last year, and that specifically is one of the components of what we are doing to address the opioid problem. I think one of the common examples that's used is in the day whenever you went to have your wisdom teeth out and you went to have that happen, the dentist might prescribe to you painkillers afterwards. And the question is, do you need 3 days, 5 days, 7 days, or a 30-day supply of the medication? And that's where quantity limits come into play and can directly help impact the problem that we're currently seeing with opioid abuse.
But is it also a waste question? I mean, so many drugs actually get thrown away, and which obviously has huge environmental impacts as well, but also a cost issue for us. Why are we paying for drugs that aren't being utilized? Now, part of it is an adherence problem, perhaps, but are we looking at the quantities prescribed in that context as well, beyond opioids?
It's an issue of quantity on hand, need for the particular diagnosis, having enough in order to treat it on a short-term acute usage versus not impacting those people that do in fact need the medication for chronic needs such as in oncology, for instance.
Sure.
So that clearly is part of the program, and what should be looked at is the waste as well as having leftovers, which people typically keep at home, which contributes to the overall abuse potential by having them available for people in the household.
Okay, well, this has been a really stimulating conversation. Thanks to all of our panelists for an excellent panel. Next, we're going to move on to our final healthcare session about our established regions for contracting agencies. It's the first of several conversations that we're going to have throughout the year to assess how well our current regions are supporting our strategic goal of healthcare affordability. So, Liana, please begin whenever you're ready. Thanks.
No, that's okay, because I just, can you give me a second? Yes, you may.
This is not break time, sorry to say. We're actually going to move right into the next panel. We're just waiting for the panel to set up.
Yes, you got to sit here. Yeah, Leanne, I want you here. Leanne, I want you to sit at the bar. All right.
I'm going to sit here.
No, you're going to sit, because it goes in order. You're the last, she's after you, though. Huh? He is after, he goes, no, it's you. Right. Right. So do we have it up yet?
I'm going to put it up right now.
Okay.
There were 3 slides.
Yeah, sorry, we were going to do this at break.
So
Yeah.
it's okay, but just cue me and I'll try to get the right one.
Oh, there was a change in slide? No, she just wanted to make sure that the slides were in the right order. Oh, so she was just wanting to do that at break. Oh, perfect. Yes, please. Thank you. Thanks, Mom. Thank you.
I know everyone wants to.
Yep, we're all clicking for ourselves.
That was my question. Okay, we are going to get restarted. If I could ask everyone to quiet down. Go ahead, Ms. Bailey Crimmins.
All right. Good afternoon, Madam Chair. Is it on? I'm not on. Good morning. Okay. All right. Good afternoon. Yeah, good morning. Good afternoon, Madam President and members of the board. Leanna Bailey Crimmins, CalPERS team member. Today's information item will be one of several presentations that you will receive related to regions and regional factors before the 2020 rate development process. Over the next 12 months, our objective is to determine if changes to the regions and/or regional factors will benefit the CalPERS members and/or employers. Co-presenting with me today is Sherry Little, the Division Chief over the rate development process, and Gary McCollum, who is our health actuary. Our objective today is three things. First is to provide a background and a list of historical decisions that the board has made in relation to regions. The second is to share observations on how regions and regional factors contribute to the regional rates. And then lastly, establish next steps and a roadmap on where CalPERS will work with our stakeholders, gain input, work with third-party experts such as economists and actuaries to basically assist us with the decision-making process. The regions are an important topic, and we are performing the assessment now for three reasons. The first is the regions were established 13 years ago, and our employers have consistently reported to us that over the 13 years that they believe the cost of care has changed in their counties. And one of the letters that you have in front of you is from one of our employers, Butte County. This is just one of the employers that has reached out to us. Also, we would all agree the world of healthcare is continuing to evolve. Hospitals merge, we have provider networks added and removed, and so we believe at CalPERS it's a good best practice to put in place that at least every 5 years to assess the regions and determine if any significant changes has been made. And then lastly, over the last 3 or 4 years, we've seen specific regions have some premium volatility. So we're analyzing the data, looking at it with experts, and determining if there are changes that could be implemented to reduce this volatility that we're seeing. Regions and regional factors are separate but very interrelated categories when it comes to establishing regional rates. Both impact our per member, per month premiums for our public agencies and schools. In fact, CalPERS was notified that for 2017, we lost San Luis Obispo as one of our health providers. So of the 8,000 approximate lives that we lost, 4,600 of those total covered lives was from a single employer. And one of the reasons they cited was because of the volatility they've seen in the regions. Both regions and regional factors requires an in-depth analysis. And the board will receive staff recommendations in December to determine if one, both, or none of these categories require change. So let's look at the state. Regions are basically, for the CalPERS, we have 5 regions, and it's based on the average cost of care. So if you took a single family and moved them around the state, how much would the cost of care be in the specific region for that same family? So in a designated region, for public agencies and schools, they pay the same per monthly premium as someone else in that particular region. So for this particular slide, you will see that for Bay Area, Nevada County, and Lodi, which is San Joaquin County, pay the same monthly premium as employers and as members in San Francisco. And in this case, it's $1,371.84 for single basic. So I think we would all agree that Nevada and San Joaquin County have very different annual income, cost of living and socioeconomic factors. But 13 years ago, when Milliman established the regions, they looked not necessarily on socioeconomic factors, but what was the cost of care in those counties. And so we owe it to you to look at each of the counties over the next 12 months to see if the average cost of care still means that they stay in the exact regions that are drawn today. And then when it comes to regional factors within a region, each of the HMO carriers are allowed to use their own actuary methodology to come up with their average cost of care. Now, as you're aware through the rate development process, this is actually reviewed by the team to validate that the medical claim experience is accurate, and we actually have a third party validated as well. But now that we have 9 HMOs, which competitive plan choice is important, we have seen certain plans have smaller footprints in specific regions, which we believe is contributing to some of the volatility. So as you can see here, year over year, premium fluctuations are expected, but from 2000, and I can't read it there, over the last 4 years, you've seen for a single premium for other Northern, this specific health plan, an individual has gone from $677 per month, per member per month premium to $1,200 per member per month premium. And just this last year, which we did discuss through the rate development process, this specific plan had gone up over 40%. Since we've seen this volatility, again, this is a rationale of why we need to look into this. And the question is, should we be allowing the carriers to come up with their own actuary methods? So this is an urgent issue. But regions and regional factors are very complex. This is not the first time that this topic has been brought in front of this board. And both impact our members and our employers. So therefore, the health program and the actuary team believe this initiative deserves rigor, time, and the level of analysis necessary to assess the data and determine if change is warranted. So with that, I'd like to turn the presentation over to Sherry Little, who's going to talk to us about some of the background and historical decisions that's been made. And then after that, we'll turn it over to Gary, who will go more deeper into how we actually calculate these factors.
Good afternoon, Madam Chair, board members. Sherry Little from the CalPERS team. As Leanna mentioned, today we're here to talk about regions, and what we'd like to do is kind of give you a brief overview, the background, the history, and just general information in a series of conversations we'll be having over the next few meetings. We'd like to help you understand the methodology and the challenges of geographic regions, what's worked and what hasn't worked in the past, specifically as it relates to premium volatility, especially when it goes up significantly higher in a region than the state average. It appears to be the primary issues for the public agencies and directly impacts their annual budgets and their ability to provide affordable health care to their employees. Generally speaking, the implementation of regions has been a success in meeting the purposes, with the intention of CalPERS to create a stable risk pool by attracting and retaining as many public agencies as possible over the years. On the whole, we've been able to develop regions that make economic and geographic sense for public agency membership while also providing some stability. Regions were first created to retain and attract. In Los Angeles County alone, our public agency population has increased over 60% between 2005 and 2017. And our total public agency population has grown by 26%. So, just by way of history, regions have been an ongoing topic of conversation with the board, as you know. The slide before you illustrates critical dates and decisions. In 2003, public agencies and specific bargaining units from 8 additional public agencies withdrew from PUMCA. We lost 7 agencies in the north and 28 in the south. That amounted to roughly 17,000 subscribers, mostly in the South, that were paying above market premiums to stay with CalPERS. In 2005, to help stabilize the CalPERS Health Program risk pool, the board approved regions to better align the premiums with the actual market experience. In 2009, our board approved the creation of a 5th region in Sacramento and carved out the Sacramento Bay Area comprised of Sacramento, El Dorado, and Placer counties. Most recently, the board approved the movement of Yolo County into the Sacramento region based upon a reassessment of the regional costs into the area. So in addition to these factors and these key events, as most of you are familiar, during the rate development process every year between March and June, we come to the board with regional rates and factors for discussion and for board approval. We continue to share the data as often as possible to help you understand the impacts and to provide you with the best data available so that we can all make informed decisions. Although we've had a lot of success, we've also had a lot of challenges, as you are well aware and you've heard. Premium volatility goes up and down. We hear feedback from our teams, our marketing teams as they go out into the Bay Area and other regions, the uncertainty and the volatility it presents in their annual budgets for planning and budgeting purposes. One example Leanna already mentioned, but another one would be an HMO in the Bay Area that had a 13% premium decrease in 2017, and another that had a 29% increase in the same year. We also saw the same plan go from a 15.7% increase in one year to a 7% decrease in the next. So with respect to the inequities and the geographic regions that they may impose, another issue is the regional factors based on these regions. Mr. McCollum will speak more to that later. And in addition to the San Luis Obispo example that Leanna mentioned, we had 8 additional public agencies that terminated in effective 2018. This included the County of Butte. You have a letter before you they submitted last night. And Alkalani's High School with roughly 1,379 members. And according to both plans, they were leaving because of the volatility and the fact that they were seeking lower cost plans. In 2004 and prior years, CalPERS charged public agencies a flat statewide rate for all of our plans, varying by family size and Medicare status. Today we have 5 regions, as you know, the Bay Area, Sacramento, Los Angeles, other northern, other southern. We hired third-party actuaries, Milliman, to define really the reason for the regions initially and propose regional assignments based on location, membership, and relative cost similarities. There are a number of reasons for these regional differences. They include demographic factors, disease burdens, provider practices and reimbursement levels, and regional cost factors that were developed originally, intentionally designed to reflect all of these in rate development. This results in a series of actuarial calculations Mr. McCollum will speak to with geographical cost factors that reflect the data-driven costs, which is why premiums vary so much county by county. So with that, I'd like to turn it to Mr. McCollum.
Okay, thank you, Sherry. Good afternoon, Madam President, other members of the board, Gary McCollum, CalPERS team member. Now, first of all, I just want to point out and remind you all that this discussion regarding regions and regional rates applies only to the basic plans. The rates for the Medicare plans do not vary by our regions, so just to make sure everyone realizes that. So as Sherry pointed out, there's currently 5 regions, and the 5th region was carved out of what was originally called the Bay Area / Sacramento region. It's now the Bay Area is a region in Sacramento. But back when the original 4 regions were created for the 2005 rates, there was one simple fact, and that is that the cost of health care in the southern part of the state is less expensive than the cost of health care in the northern part. I'm sure you've all heard that many times, but it doesn't hurt to remind you. So essentially, the 4 regions that were created just took the state in the southern part, and they created a Los Angeles region, and then the rest of the southern part of the state. And then in the north, they took the Bay Area region, which, as you can see, kind of goes northeast up through Sacramento and all the way essentially to the Nevada border, and then the rest of the northern part of the state. So before we talk about regions, let's start with the state as a single region. Nice and simple. I wish the regional rates were just as simple. But the state of California employees have a single rate, regardless of where they reside in the state. So in the rate development process, we start by calculating for each health plan offering a single rate for their total population, both state and PA members. Then, to get our regional rates, which are applicable only to the PA members, not to the state members, are calculated by multiplying the state rate that we've calculated by the regional factor. So, what is a regional factor? Everyone's waiting for this, aren't we? Yeah. So the regional factor represents the cost of health care in that region in relation to the average cost of health care in the whole state. So a simple way to look at it, for a standard group of people, we need to ask one question. What would it cost to provide care in one region compared to another region for that same group of people? So this factor is calculated for each health plan, and that represents, based on the health plan, it represents, as Sherry said, the reimbursement arrangements, the location of the members within the region, and also the practice pattern of the providers within that region. So this means that each health plan will have different factors in a region. Even though a region might have an average cost of health care for that region, the health plans within the region will have different factors because they have different distributions of members and locations. So let me give you a very simple example. If we had a regional factor for Los Angeles, for the Los Angeles region of 0.8, that means that the average cost of care in that region is 80% of the average cost of care in the state as a whole. Or put another way, the Los Angeles region is 20% less expensive or cheaper than the state. Likewise, if the regional factor for the Bay Area is 1.2, that means that the Bay Area is 20% more expensive than the state as a whole. So within a region, of course, there's also differences in the cost between the counties. So in one region, you could have one county with a factor of 0.92. You could have another county with a factor of 0.87. You could have a third county with a factor of 0.94. To get the average cost of the region, we take those counties and combine them to calculate an average cost for the region. Now, CalPERS calculates the regional factors for the PPO plans. And historically, CalPERS has had the HMO plans calculate the regional factors for their plans and then submit them to us for our review. During the RDP, the factors are evaluated by us and discussions are held with the plans, as Sherry pointed out. And as we have transitioned to multiple plans in the last 5 years, we have seen increased volatility in these regional factors. So that's why this item is being brought to your attention at this time.
Gary, just for the benefit of our new board members, the RDP is the rate development process.
Oh, I'm
right.
Yes, thank you. I meant to say that.
Thank you.
Thank you very much. So As I said, the regional factors, or the regional premiums, excuse me, are calculated by multiplying the state rate by the regional factor. Now, the final regional factors are required to be set such that the total projected premium that's collected using regional rates has to be the same as if we had used the state rate in that region for those PA members. So again, let me give you a simple example. Let's assume there's just two regions, north and south, and there's just one member in each region. So if the state rate is $100, we would collect $200 for those two people. And using my same examples, if the south region is 0.8, then the PA premium for that region would be $80. And if the north was 1.2, the PA premium for the north would be $120. So the $80 collected in the south plus the $120 collected in the north equals the same $200 that we would collect using the state premium. So I'll now turn the discussion back to Liana to discuss the timeline.
Thank you, Gary. So in closing, as you can tell, regions and regional factors are complex topics. And as we've stated before, we owe it to you and the stakeholders to do an in-depth analysis and bring that back to you in order to just determine if there is a change needed for the 2020 rate development process. So over the next 6 to 8 months, we will analyze both the regions and regional factors separate, but the understanding that they are very much interrelated. So after the rate negotiations, that's a pretty intense time, but we're going to be doing analysis along the way. In July, we'll bring back market and industry metrics. So who's doing it well out there? What does the market bear? And then in September, we want to share active retiree and employer feedback. We want to make sure few of our stakeholders have really talked about wanting to be active in this process, so we want to make sure that we give them that opportunity. And then in November, provide options and considerations with pros and cons, with a hope in December to be able to provide a team recommendation for your decision. Madam President, that concludes our presentation, and we are now available for questions.
Thank you. Are there any questions on this topic? Mr. Slayton.
Thank you, Madam President. I remember very well the 2014 meeting where we were able to move one of the counties, Yolo County, into Sacramento. And there were a lot of reasons for that, and a lot of it had to do with not pure pricing, but providers and the provider networks and where people were going for their health care. So I guess what I'm saying is I think there's going to be some advocacy, I would assume, on the part of some jurisdictions to encourage us to shift and adjust, make further adjustments or shifts. So I just want to make sure that the stakeholder feedback portion of this, that we are really reaching out to the employers to make sure they have a chance to weigh in on this, on their opinion regarding what regions they believe they should be in given their member profiles. Thank you.
Terrific. Thank you. Mr. LaFaso.
Thank you, Madam President. Two questions, if I can squeeze them in. First, Mr. McCollum, there's something I'm a little confused about. I think I heard you say that the HMO plans use the same three basic components to develop their regional rating factor as were used to develop the original model by Milliman in 2012. But then you say that they do the calculation themselves. Are we using the same basic data points in our year-to-year establishment of the factors, or have we veered from that, or is there some inconsistency in the application?
I would say that in general, they are using the same basic model. We need to do more in-depth discussions with the plans to find out more specifics. That's part of what we are going to be doing over the next several months.
Okay. Just my second question is, the way you describe your last example of the two individuals, one north-south, $80 and $120, since there are no transfer payments in this system, why does it have to be a zero-sum game? why is the system designed such that if one region's rate factor, as it were, goes down, another region's factor has to go up? If they exist as standalone, competing externally from the CalPERS system, that is, other purchasers, et cetera, why does it have to be a zero-sum game?
Okay. My understanding is that the enabling, and I'm not sure whether it was legislation or regulation or what, but whatever enabled us to charge regional premiums back in 2005 had that requirement that the amount collected in the regional premiums had to be the same as if it was collected under the state premium.
Okay. I mean, just as a final comment, given the process that Mr. Slayton sort of anticipated, there's an inherent tension in the system, and if there's a design reason why that has to be, so be it, but perhaps you all can recall why we designed it this way and if the regulation needs to be changed. Anyway, you get the point.
Well, there's a complicating factor. No matter where you draw the boundaries for the regions, you're going to have contiguous counties in different regions. And there's always the possibility that the one county benefits from a lower cost region and the county that sits right beside it, butts up against it, is in a higher cost region, and they will squawk and say, well, wait a minute, I should be in that region. So there's always that tension that you talked about. Unless you draw 58 regions, one for each county, or you eliminate regions and go back to a single rate for the whole state, you're going to have that tension.
I follow you, and I'm not trying to dispute, but it's one thing if that's directly related to costs in that area that are things that people can see and experience and appear rational to people in that area. It's another thing if it's because it's thrown in some complex system where, because a factor changes in Butte County, another factor must necessarily change in, I don't know, Santa Cruz County, which creates systems that just don't reflect reality. There's this complicated architecture that I don't understand, and I'm trying to ask you about it, but there seems to be this zero-sum game concept in the system, and I'm questioning why it has to be.
Okay, thank you. Ms. Taylor.
Yes, thank you. Thank you for the presentation. I had a question, and now I think you might have answered it, on how did we end up with San Joaquin, Amador, Sutter, Yuba, and Nevada in the Bay Area? I wasn't here for that, so I just wanted to know. Does anybody have an answer to that one?
I have no answer.
We don't have any idea.
Originally, it was the Bay Area Sacramento region, and then we carved out
Sacramento.
Right. Yeah.
That's why.
Which is
and
just
Sacramento, if you continue.
3 counties, it looks like.
Yeah.
And it was based on average cost of care. So looking at some of the counties, they may have had situations where high hospital costs, very few hospitals 13 years ago, providers not wanting to be a part of networks. So when Milliman did the full analysis, they brought all that into play as they were drawing the lines. That's why now, 13 years later, we owe it to you to do the analysis to say, should there be a change? And
Okay.
so because it is hard, as you can imagine, going to Lodi employers and recruiting them when they see that their single basic premium is the same as San Francisco.
And is San Francisco higher than ours, than Sacramento?
The single basic premium is the same premium as 1,300 and, what was I can't remember what it was. 13.
Was it the same?
Yeah, they were.
As Sacramento?
No, not Sacramento.
Not
no,
state.
no.
Not state. I meant
So
Sacramento.
San Francisco and Nevada County and same as Lodi for single basic $1,371.84.
And we didn't get a comparison with
We don't have the
neighboring
Sacramento.
We don't
regions.
have Sacramento on
Okay.
here.
I'm just curious. So we are looking into that, and then my other question was, it looked like we had, and I know that the LA region is cheapest of the whole state, even lower than the state rates, but it looked like at one point people started dropping out mainly in LA. But in other regions, because the state rate was too high, now it's looking like the state rate's looking pretty reasonable, except for LA. So I just thought I'd mention that.
Your point
Thank
well
you.
taken. That's why we need to do the analysis.
Thank you. Any further questions before we move on? Mr. Slayton.
Just one other clarification. I think that, and this is going to be such an interesting process we're going to go through, because you're going to start with refreshing the data that's going to tell us what the cost differentials are. But then this body also is a political body. I mean, we react to our members, we react to the pressures we have from employees, employers, retirees. And so therefore, then we have to take that data and say, well, are there areas where it, even though the data says this, it, because of other factors like providers, provider networks, that drive us to possibly a potentially slightly different conclusion than what just the pure data would say. And that's good. It's good that it comes to us and that we get to add these other factors in making a decision. So I look forward to it. It'll be a robust discussion.
Well, this, as Liana said, this is just the first of many conversations over the next several months. And it will certainly come back many times for consideration with additional information and then ultimately for a decision on how to move forward. So thank you so much. We are going to break now for 15 minutes and we'll come back at 3:30. Thanks. 3:35.